MoveOn has forums every couple months on issues that are in the national discourse. And this evening we're going to talk about single-payer health insurance. Our speaker is from Physicians for a National Health Program, the nation's leading advocacy group. Ann Sheets received her medical degree from the University of Illinois and is board certified in internal medicine, specializing in geriatrics, practicing in Chicago, except she recently retired to be a full-time volunteer for Physicians for a National Health Program. Ann, thank you for being with us tonight.
Okay, so what happens when you have copays and deductibles? The reason people give for saying we should have copays and deductibles, they say this decreases the use of unnecessary services. Well, in fact, it decreases the use of necessary services. We hear stories about this all the time. Somebody has abdominal pain, doesn't want to take the chance of going to the emergency room and getting stuck with the bill. Maybe it's nothing, and then they have a burst appendix, and they might die. I just heard about a young man, his wife was pregnant with their first child, died of appendicitis. He was thinking about the expenses of his wife's pregnancy and childbirth. He didn't want to take the risk of going to the emergency room and having a bill. Now he has a fatherless child to be born. So this is a tragedy. It results in the underuse of primary care services, of preventive services, any kind of services. And this is not the way to reduce the use of unnecessary care. There are ways to reduce the use of unnecessary care. One way is to fund primary care so that people are not encouraged to go to surgeons and people who perform high-tech care. So you see your primary care physician, if your primary care physician can't take care of it, you go to a higher-tech specialist. You don't go to the high-tech specialist first. It's the thing about if you have a hammer, you see nails. Well, that's what happens too if you're a surgeon. You know, you see somebody, they have back pain, you think about surgery. If you go to your primary care physician, you have back pain, your primary care physician thinks about exercise. So there's a difference in that. And then if there are some things that should never happen, physicians should not be able to refer their own patients for tests that they make money off of. That's unethical. But it still goes on. What about choice? Okay, currently, most people who get their insurance through their employer have only one plan offered to them. If you have more than one plan offered, it's usually all of the plans have restricted networks, out-of-pocket costs. You're choosing between two bad things. Almost all private health plans have some kind of limits on the doctors and hospitals you can go to. So if you go out of network, you have to pay more. So that's what people have now. And then, of course, some people have only one plan offered. Some people have a couple that are bad, nothing that's good for them. Even when we have PPACA and EFAC and you have the insurance exchanges, you're going to get a choice. But all of the choices are going to have expenses attached to them and restricted networks. They're not going to be good. So what about under Medicare for All? Well, everybody's in the same program. Every doctor, every hospital, every hospice, every home health agency, every pharmacy, all in the same program. You have complete choice of doctors and hospitals and other services. Now, we're not going to force people to join the program, but when Medicare first started, every doctor, every hospital took Medicare. We're now at the point, because Medicare has deteriorated, which I'll come back to, where there are doctors who don't accept Medicare patients, and there are hospitals that are trying not to accept Medicare patients. But if you have a uniform program for everybody, we'll go back to the situation where every provider takes every patient. And this, of course, is the best way to have people get good care. You find a doctor who suits you. The same doctor doesn't suit everybody. Okay, now, this is another tragic statistic. In 2008, the United States was last among 19 countries in mortality that was amenable to medical care. So this is people who died early of diseases that could be treated. And that we got worse between 2006 and 2008. And how would Medicare for All address this? Well, first of all, there's no such thing as you can't go to the doctor because you can't afford it, or you can't get your medicine because you can't afford it. You will be able to pick the doctor that suits you and stay with that doctor. Every time your employer buys a new kind of health insurance, you don't have to change doctors. That's a tremendous benefit in quality of care. Then we'll have national standards for reporting things. That doesn't mean that what gets reported is your confidential information. But for instance, you have codes. Everybody who has diabetes goes into a data code. You can see how people got treated, in mass numbers. It doesn't do any good to see how one person got treated. You see how millions of people got treated. You see that one treatment appeared to be more effective than something else. That gives you some information to go by. You can divide it up by different populations. People of African American descent and European descent are in many ways much the same, but there are some things in which they diverge. You have enough people to collect data on that and advise physicians and hospitals on what works. You can also, when you have a national plan, have health information technology, medical records, electronic medical records that are focused on clinical information, your health care, and what your physician needs to know about you to take care of you, not on billing. Right now we have hundreds of electronic medical records, and the most important part of that record is how you bill, not what the doctor needs to know in order to take care of people, okay? So get rid of the private health insurance industry and we can focus on clinical information. Okay, so some of the things that PPACA focuses on, comparative effectiveness research. Yes, this is good, but what's the good of having comparative effectiveness research if you can't afford to get the most effective treatment when you go to the doctor? Innovations on testing new payment and service delivery models, but what they're not going to test is getting rid of insurance so you can go to whichever doctor you want and stay with that doctor. And so once you've started going to a particular hospital, you don't have to change because your insurance company dropped them from your network. And all of your records are there, doctors who know you, nurses who know you, and you can't go there any longer. Some of these things I think are very problematic. Value-based purchasing, so having hospitals report various quality measures. Well, there is a lot of good to be said about that. The problem is, we know that maybe the greatest determinant of health, beyond blood pressure, cholesterol, lots of these other things, is economic class. So what about a hospital that's in a poor neighborhood? Is that hospital going to get penalized because their outcomes are not as good as a hospital in a wealthy neighborhood? Those are some of the things we worry about. Readmission penalties. Your patients go home. What if they can't afford their medicine? What if they can't afford to keep their doctor's appointments? They come back in the hospital and the hospital gets penalized for that? That doesn't make sense. That doesn't make sense. So we're aiming at the wrong thing. These are just ways to find somebody to blame and to take the onus off of where it really belongs, which is the health insurance industry. Then reducing hospital payments for hospital-acquired conditions. Well, again, you could say there's something to be said for that. But supposing the person is at home, there's a staphylococcus that's prevalent in the community, you have it in your nose or your skin, you go in the hospital, your immunity is suppressed because you're sick, and you get an active infection. Well, the problem wasn't the hospital. The problem was that this condition is prevalent in the community. That's what needs to be addressed. This way of addressing it is not dealing with the problem. Okay, costs of healthcare. That's something we're all concerned about. You can see here the United States is the top line. And you can see all these other countries, the lines are going up, but the United States, it has a much steeper curve. And this started around 1980. Why it started in 1980 is beyond this lecture, but I can just say that in 1980, we have the first use of the term the medical industrial complex. We can also say 1980 was the early years of the HMOs. So HMOs are supposed to reduce healthcare spending. They didn't do it. You have a lot of concern at this time also with merging and of companies, a lot more of the for-profit motive coming into medical care. Before that, you had not-for-profit hospitals, not-for-profit insurance companies, and you see, starting before that, but maybe accelerating after 1980, that it shifts to a for-profit, market-based system. So in the United States, all this money that I told you we spend, what are we paying for? Well, a patchwork quilt of things, for one thing, an incredibly complex system, thousands of insurance plans, armies of people to deny coverage and payments, that's what they do, collect payments on the other side, determine eligibility. So this is a picture, you can, I don't know if you can even see it down here, from 1970 to 2008, the growth in the physician the number of physicians in the United States. And that big shaded area, that's the growth in the administrative personnel in the healthcare system between 1970 and 2008. You can see this enormous number of people. Those are the people that are devoted to finding ways to not pay claims, and on the other hand, to find ways to get claims paid. But you know what that doesn't include? It doesn't include any dollar value of the time that patients and families spend dealing with insurance. Nobody has ever put a dollar value to that. I don't even know where our costs would be if we did that.